largely because of low efficiency. And then what we can do is just eliminate all the calcium which is necessary for all these processes, both for the coagulation process and for the inflammatory operations, by giving citrate, chelating calcium and thus stopping all these processes. So anticoagulation is a balance between providing optimized filter or circulate survival, which some say must be at least 24 hours. Others tend to have longer survival, or want to have longer survival, like 72 hours. And on the other hand, you want to minimize the risk of bleeding, which is reported between 5 and 25%. We have different forms of anticoagulation. Generally, you can consider systemic anticoagulation, where the patient is completely anticoagulated, but usually when we are using an extracorporeal system, you can add the anticoagulant into the extracorporeal system, and so you do low-grade systemic anticoagulation because the anticoagulation effects in the patients are lower than in the extracorporeal system, which is usually when you're using heparins, heparinoids, or thrombin inhibitors and giving them to the extracorporeal system. On the other hand, you have regional anticoagulation, either by giving heparin and neutralizing heparin at the end of the circuit by giving protamine sulfate, or by using citrate for regional anticoagulation. As we heard before by Marlies Osterman, most people do not anticoagulate, which where I completely agree with George that we should anticoagulate the patients, but the most frequently used anticoagulant is still heparin. When you use how it's produced, it's majorly extracted from tissue, like big bowels. It's purified, and then you have a huge range of molecular weight sugar molecules, partly binding antithrombin capabilities. The half-life of heparin is very short, it's around 1 hour, and the price is very low. That's why people like to use it. And the other advantage is that it is quite easily to be monitored. What we have to keep in mind is, since the effect is mainly on factor 10 and on thrombin about 50-50, and this effect is also mainly dependent on antithrombin. You don't have any heparin effect or largely decreased heparin effect if you have low levels antithrombin. As I said, it's easy to monitor by using PTT, and as I said, I think most people are using heparinization as a low-grade systemic heparinization. This is due to the fact that when you start using low doses of heparin, you get dramatically reduced rate of coagulation in the system, whereas the rate of hemorrhage is very slowly increasing, and then also at higher levels it's going exponentially up. So you tend to stay in the lower range of systemic anticoagulation, have the extracorporeal system anticoagulated. Why does this work quite well with heparin? As I said, heparin has a large range of molecular, with large sizes of up to 30,000 and small sizes, and the large sizes are cleared by the reticular endothelial system, whereas the small sizes are cleared by the kidney by filtration. And when you have acute kidney injury, these small sizes are increasing more than the large sizes, so you're having a better anticoagulative effect in the extracorporeal system, even if PTT seems to be quite low. As I said, you have to remember, if you're using heparin, you need adequate levels of 83. This has been shown in this comparative cohort trial where Dishodoron added 83 to levels above 70%, and then they could show that they have a dramatically increased filter survival when using heparin. This is an issue. I think that when using heparin, we have to keep in mind that we have quite frequent incidents of so-called heparin resistance, which is partly due to a lack of antithrombin, which is consumed or proteolyzed on the one hand, but on the other hand, you have a lot of unspecific heparin binding to other sites than just in the coagulation system. So it's binding to necrotic cells, and it's also binding to acute phase proteins. So you have an inactivation of heparin, and you might need higher doses to get adequate anticoagulation, in addition to the fact that you need antithrombin. And I don't know what I did now. The next thing is that heparin is not neutral in terms of inflammation. It has both pro and anti-inflammatory action. So heparin is influencing our inflammatory system. How about the low molecular weight heparins? I think they are more neutral. And the other difference to unfractioned heparin is that the direct action is mainly against activated factor 10. You see you have a relationship of 4:1 in activity against factor 10A versus thrombin, and it is not dependent on antithrombin, so you have a quite independent action of low molecular heparin. There are different other advantages of low molecular weight heparins, that you have a lower incidence of heparin-induced thrombocytopenia, and you have less activation of platelets and less inactivation by platelet factor 4, and has no metabolic side effect and is quite constantly bioavailable. There are some disadvantages of low molecular weight. It's just the increased half-time, which is already higher than unfractionated heparin, but it's getting even higher if the kidney is failing. And you need anti-10A monitoring, which is a little bit more complicated and somewhat more expensive than PTT, and you can only partly antagonize it by protamine. However, you can do the same as you do it with the heparin. You can put low molecular weight heparin inside the extracorporeal circuit, and then you get low systemic anticoagulation and high extracorporeal anticoagulation, as we showed in a trial years before, where we put enoxaparin in the extracorporeal system, and you can see here this is the anti-10A activity in the extracorporeal system, and this is the patient activity, and you see it's much higher in the extracorporeal system, and even 24 and 72 hours later, this relationship remains constant, and it's not accumulating when you are monitoring the dose via factor 10A. So you have low systemic anticoagulation and all the benefits of low molecular weight heparin, which led to significantly increased filter survival of 50%, lower costs, and the same rate of bleeding as you had with low-dose heparin. So low molecular weight heparin seems to be a little bit more effective, and you can see this in dialysis patients when you're looking at the membranes treated with low molecular weight heparin as compared to unfractured heparin. You just see it obviously it's improved. In case of heparin-induced thrombocytopenia, you cannot go with heparins. You have to switch to alternatives. One alternative is danaparoid, which is a mixture of heparin, dermaton, and chondroitin sulfate, but it works pretty much the same as low molecular weight heparins. You can monitor anti-10A activity to dose. The problem with danaparoids is they have an extremely long half-time, which is still further going up when the kidney is failing and you have some cross-reactivity. That's why generally nowadays it's recommended to go to direct thrombin inhibitors. And there are two major players. One is agatropan, which is primarily metabolized by the liver, and the other is bivalirudin, which is hydrolyzed and needs neither the liver nor the kidney for elimination. But it's not registered for use in CVVHD. It is highly priced. So agatropan is the substance of choice in heparin-induced thrombocytopenia. You can monitor it easily, like heparin with APTT. You have to consider that it tends to have higher anticoagulation effectiveness when the patient has a diminished liver function or is in liver failure. So this is the major caution by using this substance. So when you look at the picture, unfractionated, low molecular weight heparin and citrate, and you see that's good, better, best. Citrate seems to have the optimal protection, provide the optimal protection of the membrane, at least in this 4-hour dialysis period where you see just the clean membranes of citrate, and that's why citrate is becoming so popular. It's working by chelating calcium, I told you before, which inhibits all the steps in the coagulation system. And just basically to show you the principle is you are giving citrate at a fixed certain rate to the blood flow, so that you get a certain level of citrate within the blood, which you can determine by measuring the ionized calcium in the extracorporeal system. Calcium and citrate are eliminated somewhat by the filter, depending on the filtration rate, the dialysis flow you're using, and the rest of the calcium citrate is going back to the patient, and you're giving calcium for the loss of the calcium in the filtration with the citrate. And it's a little bit more complicated in terms of monitoring. You have to monitor the patient so that ionized calcium is not going below a certain threshold of around 1, endangering the patient. And the other thing is you have to repeatedly check the circulate so that it is adequately anticoagulated. And then you have to check the metabolism of citrate, see if pH is staying stable, and if you have any indication of accumulation, which would be reflected by an increase of the ratio of total calcium versus ionized calcium. So it is a little bit more complicated. You need more tests, and you have to be more aware of possible complications. And as I said, your citrate clearance will depend on because it has a very low seeding coefficient like that of urea. It's completely eliminated by filtration or dialysis. So if you are increasing your ultrafiltration rate, you are also increasing citrate clearance, and you have to keep that in mind. Now, this is a very nice system because the extracorporeal circuit is anticoagulated. The patient is not anticoagulated, so you have real, true regional anticoagulation with its caveats. What we mainly have to consider is that citrate has to be metabolized. It's mainly metabolized in the liver, and it gives us free molecules of bicarbonate by metabolizing citrate. It has a very short half-life time, so for about 5 minutes it should be eliminated. So usually it should not accumulate as long as the liver is working adequately. Now there have been 3 recent trials which were looking specifically at this specific group of patients with liver failure or liver impairment, and I think these studies are important. That's why I'm showing that to you, because that was the major limitation for citrate application, that if you have liver failure that would be a contraindication. These are the worst patients. These are the patients with complete liver failure who are needing molecular Mars system, so sort of a liver replacement system, and you see that has been used for average of 20 hours in this study from Vienna. The patients have been considerably sick with a dramatically reduced prothrombin time of 36% and elevated bilirubin, thrombocytopenia. We see the platelets stay more or less stable. They're a little going down. This was the only major significant change, but what was interesting is, and this is the ratio which indicates accumulation, is that you have some